Good morning, everyone. It's really my honor to be here to giving this keynote talk. The title of my talk this morning is the receptor must highly pathogenic interacting GM-CSF positive T helper cell and IL-23 positive macrophage, and therefore rendering it attractive therapeutic target for rheumatoid arthritis. So the first thing I'm going to give you some background of DR5, the receptor, and also its antibody, Tri-8. So DR5 is a pro-apoptosis molecule which can induce cell death in a variety of cells by engaging its ligand trail and also the anti-DR5 antibody. Tri-8 is a monoclonal anti-human DR5 antibody which had been invented about 10 years ago, and it can be in the clinical trial for human cancer therapies. It can induce apoptosis upon binding to its receptor DR5. The DAP receptor includes a variety of memory, including DR4, DR5, a decoy receptor R1, R2, and also a soluble receptor called OPG. Upon binding to its ligand or antibody, DR5 can mediate apoptosis within the cell. Our previous study had demonstrated that anti-DR5 antibody Tri-8 can induce apoptosis in fibroblast cell from synovia tissue from RA patients. As the figure show here, this effect is highly dramatic. And the advantage of Tri-8 compared to its natural ligand trial is that Tri-8 is more specific to the natural ligand, and it also has a much longer half-life and lower liver toxicity. So the question we are trying to address here is that can Tri-8 also induce apoptosis in pathogenic macrophage and T cell from rheumatoid arthritis patient? We're trying to answer this question using the animal model before we do the human study. So the strategy we use to demonstrate this efficacy of Tri-8 killing effect in human in mouse model. We were using a mouse model that was humanized by transgene DR5, human DR5 into the mice. The transgene DR5 can be recognized by human DR5 antibody. Also, we're trying to control the expression of the transgene DR5 expression by different Qui-LOXP system, which enable the expression generally or macrophage specifically. And we also use the very commonly used mouse model of rheumatoid arthritis, collagen to induce arthritis, CIA. So as we know that human DR5 molecule cannot trigger the apoptosis in a mouse cells. And on the other hand, mouse DR5 cannot be recognized by anti-human DR5 antibody. Therefore, in order to perform this research, we had to generate a chimeric DR5 transgene molecule, which consists of extracellular human DR5 fragment, which link to the intracellular and transmembrane domain of the mouse DR5. Therefore, this molecule can be recognized by anti-human DR5, and it can also trigger the apoptosis in mouse cells. And we also put a flag stop sequence in front of the changing the chimeric DR5 to prevent embryonic lethality. And these transgene mice have been crossed with different quiz mice, including UBC Cre and lysozyme Cre, enable the general expression and also the macrophage target expression. This is the data from the UBC3 DR5 transgenic mice. And from the flow data here, it seems that transgenic DR5 is predominantly expressed in CD-UMB positive, GR1 positive granulocyte, and CD8-UMB positive and lysis C positive inflammatory macrophage. And a certain level of expression was also detected in CD4 T cell. We induced CIA in this DR5 transgenic UBC3 mice, and as you can see here, the mice developed severe arthritis about day 21. We give the mice TRIA at 2 time points, either early or late. And as the clinical scores show here, both treatment, either early TRIA and late TRIA, can suppress the development of arthritis, especially the early TRIA treatment, almost completely preclude the development of arthritis. And the histology also is very consistent with clinical score, which show the reduce of inflammation in the joint, and also the infiltration of MAC3 macrophage in the joint tissue. And as we expect, the TRIA also deplete the CD1B positive myeloid cell in the draining lymph node from these mice. So the next question we are trying to answer is whether the TRIA had a similar effect if we just restrict the expression of transgenic DR5 in the myeloid cell, especially macrophage. As we know, there's imbalances of M1 and M2 macrophage in RA patient. M1 macrophage is also called inflammatory macrophage, which is characterized by the high expression of TNF-alpha and a lot of inflammatory cytokine, chemokine receptor. On the other hand, anti-inflammatory macrophage is characterized by the expression of IL-4, IL-10, or TGF-beta, and other chemokine receptor. So we are trying to figure out whether TRIA, anti-DR5 antibody, can rebalance the M1 and M2 macrophage in RA arthritis. So we cross the transgenic mice to a lysozyme-free mice, which enable the macrophage-specific expression of transgenic DR5. And as the flow data showing here, transgenic DR5 is highly expressed in CD8-UMB positive macrophage isolated from the draining lymph node of CIA mice. And since we cross the mice with the lysozyme-free, therefore the transgenic DR5 is not expressed in CD4, CD8, or CD19 cell, which T cell and B cell. We didn't detect any expression of transgenic DR5. And as we expect, TRIA treatment can dramatically reduce the CD-UMB positive population in the draining lymph node. Since DR5 mediated apoptosis, we therefore trying to verify the caspase activity by using an infrared imaging approach. The mice was imaging before and after the TRIA therapy using a probe called AB50 which will detect the activity of caspase. And as the image show here, after the TRIA treatment, the signal was significantly increased in the transgenic DR5 positive mice, especially in the joint region. Therefore, it demonstrates that anti-DR5 antibody can induce the apoptosis in the joint. This is the tunnel staining, which is highly consistent with the caspase activity image. And again, TRIA treatment can suppress the development of arthritis in this changing mice that crossed with lysozyme query. And the histology also very highly consistent with the clinical score, which show the reduction of inflammation and also the reduced infiltration of macrophage in the joint, and the lower activity of trap, which indicate the elimination or inhibition of development of osteoclasts. Very consistently, we also observe a reduced level of IL-6 and IL-17 in the serum of these mice after tri-A treatment, and also the CD-UMB positive, IL-23 positive M1 macrophage is also reduced by tri-A in the draining lymph node. TS17 is also reduced. Very interesting. P3 positive Treg was increased in the draining lymph node. And we also try to determine the level of TNF-alpha, IL-23 and IRF5, IL-6, which are the M1 macrophage signature gene by real-time PCR, as the bar graph show here. Tri-A treatment almost completely remove inhibit the expression of this M1 signature gene, and it also inhibit the expression of IL-17, and on the other hand, increase the phosphate-3 expression in the draining lymph node and in the joint. So the summary of the first part, in this chimeric DR5 changing UBC mice with CIA, changing DR5 is expressed on CD1 positive macrophage and CD4 T cell. And in the DR5 changing mice caused with lysozyme query mice, changing DR5 is restricted to the macrophage. And the anti-human DR5 antibody can deplete the pathogenic macrophage and TS17 cell, and also increase Treg cell. Therefore, tri-A is a potential novel biologic agent for RA therapy. So the data I show so far is based on the CIA mice model. We're trying to figure out whether tri-X can also have a similar result or therapeutic effect in a systemic mice model of autoimmune disease. Therefore, we're trying to use another mouse model, which PTP and cis deficient mice is also called SP1, or bivalve mouse eater mice. These mice have a myeloid hyperproliferation phenotype, and these mice also develop highly progressed dermatitis, arthritis, and infection, and also pneumatitis. We cross the mouse eater mice with the transgenic DR5 mice. And the flow data show highly expect, as we expect, that transgenic DR5 is highly expressed in the CD1 positive myeloid cell. And the transgenic DR5 expression is also highly correlated with the M1 signature gene, which include IRF5, which is a transcription factor that controls the development of M1 macrophage. And it's also highly correlated with the IL-23 cytokine expression and TNF-alpha. Very interesting, tri-A treatment can almost completely remove the CD1 positive, IL-5 positive, and CD1 positive, IL-23 positive, or CD1 positive, TNF-alpha positive M1 macrophage in the draining lymph node of these mice. We then look at the different subset of T cell, including TS17, TH117, TH1, and we found that the transgenic DR5 is highly expressed in the TS17 and TH117, followed by TH1. And as TH117 cell is the major producer of GM-CSF. Therefore, we're looking at the GM-CSF positive CD4 T cell, and as the figure show here, GM-CSF positive CD4 T cell express much higher DR5 compared to the GM-CSF negative CD4 T cell. And also, tri-A treatment can remove the GM-CSF positive CD4 T cell as the figure show here. So the phenotype we observe on these mice after tri-A treatment, including the reduced inflammation in the lung, reduced inflammation in the joint, and also the reduced production of autoantibody in the serum, and reduced deposit of immune complex in the kidney. So this is the slide I show was about the mouse data, and then we move to human study. The first thing we look at the synovia tissue from IA and OA patient was look at the M1 signature gene and TH17 signature gene. The M1 signature gene we measure including P19 and GM-CSF alpha receptor IL-5 and DR5, and all of them are highly expressed in RA synovial tissue, but not in OA synovial tissue. And also, TH17 signature gene also had a similar expression pattern. They're highly expressed in the RA tissue, but not in the OA synovial tissue, which including IL-17 and GM-CSF. This data highly suggests that it's associated with the overactivation of M1 macrophage and also TH17 cell. We then look at the expression of DR5 in the cell isolated from the human synovial fluid. As the images show here, DR5 is highly expressed on the CD68 positive macrophage from the synovial fluid cell of RA patient. And also the DR5 expression is highly correlated with IL-23 and IRF5. This study was performed by real-time PCR or flow cytometry. After tri-A treatment, we observe apoptosis on the CD68 positive macrophage was visualized by a nesting file standing here. And tri-A treatment also eliminate the IL-23 positive CD68 positive inflammatory macrophage of the synovial fluid. We then look at the expression of DR5 in different subsets of T cell, including TH17, TH117, and TH1. They're highly expressed in the TH117, followed by TH17 and TH1. And again, very consistent to the mouse data we generate. Tri-A treatment on this cell can almost completely remove the TH17 and TH117. So this summary of the part 2. DR5 expression is upregulated in inflammatory macrophage and pathogenic CD4 T cell in DR5 changing mice, including CIA and mouse-eater mice. And tri-A can selectively eliminate the IRF5 positive, IL-23 positive macrophage, and also IL-17 positive GM-CSF positive CD4 T cell in both human and mouse autoimmune condition, resulting in a immune homeostasis and resolution of the inflammation. Anti-human DR5 tri-A can deplete inflammation cell population that result from overactivate GM-CSF IRF5 axis, and therefore it's potentially a novel biologic agent for RA and other autoimmune diseases. I would like to acknowledge the people that contributed to this study, including Dr. Zhong Mao and lab member, and Dr. Huicheng Shi and her lab member. And the clinical sample was provided by Dr. Kimberly, Dr. Bridge, Dr. Spalding, and Dr. Catton and Hughes. Thank you very much for your attention.
We have time for some questions and answers. Does anybody have any questions for the doctor? Here, or
Well, I think it's very interesting, your work. I've been working with osteoarthritis and apoptosis, and we have described that in osteoarthritis, apoptosis is a combination of the classical apoptosis and autophagia. In your case, have you measured LC32, that is a molecule specific for the formation of autophagic backbones? And because tunnel now is not very accepted, because also in necrosis, you can see tunnel positive cells. So the main things are caspase 3, that you have done it, LCT2 for autophagic, it's a combination. We have described with Dr. From England, Dr. Roach and Dr. Eigner, the name of apoptosis that we call it chondroptosis, because and then afterwards, in our laboratory, we have demonstrated that the chondroptosis is a combination of these two type of cell death. In your case, have you used, for example, LC32 to see if there's any autophagy, or have you used also the DNA internucleosome, the ladder signal for apoptosis?
That's a very important question. However, we haven't looked at the autophagy, including the marker you mentioned. We haven't looked at it. We only look at the apoptosis so far, right? So we haven't looked at that, but it's definitely a very interesting thing to look at in the future. And I agree that the tunnel staining might not be a best approach to, it's probably not very high specific. Like it's in the joint, it's very difficult, not very easy. So thank you very much for asking.
Excuse me, Dr. Lee, a couple of very superficial question. Are the macrophage from the peripheral blood or from bone marrow or from synovial fluid? And this particular phenomenon you discovered in rheumatoid arthritis also been similarly studied in osteoarthritis, the knee joint? I heard a couple of reports indicating the macrophage, and they was also directly, indirectly affect the patient with osteoarthritis, similar to what you reported in the patient with rheumatoid arthritis.
In our mouse study, the macrophage, we major look at the cell was isolated from the joint lymph node. It's not from the joint. The flow cytometry data was generated using the cell from the lymph node, and the histology data we look at the tissue of the joint. That's the mouse study. In human study, the cell was from the synovial fluid. It's not from the blood. There are very low level of macrophage in the circulation, but we definitely can differentiate macrophage using the human monocyte from the PBMC. But there might not be much of macrophage in the circulation. So we majorly use the cell from the synovial fluid of the eye patient. And your second question was very important and very interesting, but I kind of afraid that I probably had not a perfect answer for that, because in our data, it looks like RA is highly activated macrophage phenotype, but not in OA. But as you say, in some literature, people have reported that OA activates macrophage phenotype too. So we definitely had to look at that more carefully, see if there's any subset of macrophage that's activated in RA versus OA. There might be a different population of macrophage. So we had to look at it more carefully to define it. Thank you very much for asking.
More questions? No more? Okay. Thank you.
Thank you very much, Dr. Lee.